Hello and welcome back to GP Video Podcast by Nadia. So today I had a very busy day at clinic, started at 12 and finished around 7 or 7:30 p.m. But it was a very fulfilling day. Just reached home and just wanted to make a short video podcast on something called PMDD, on which I've already made a podcast in the past, premenstrual dysphoric disorder. But I just have got News GP is a website from RACGP that gives us new news about gives out to the GPs news about different medical interventions and medical news. So I just read an article saying that do GPs know enough about this debilitating disorder? Experts agree that there has been a dire lack of education around premenstrual dysphoric disorder, but GPs could be in the ideal situation to help. Women have reported going untreated for years with severe symptoms of premenstrual dysphoric disorder, including suicidal ideation, severe depression, and social isolation. But experts hope an increase in education and interest from GPs could open more options for patients. Associate Professor Len Clement, who has specialized in the treatment of PMDD for more than 2 decades, told News GP that this is an area that has been consistently under-resourced and is poorly understood. Because we don't completely understand what causes PMDD, the treatment is so varied, and because it's underappreciated and often not part of the usual curriculum, people often don't know a lot about it or the correct approach to it, he said. He also said that GPs need to take this extremely seriously, saying if GPs had more knowledge in this space, they would be in the ideal situation to manage this. The advantage is that they often have frequent contact and interaction with their patients, which is really important for this condition. If they do that, I think they'd be an excellent treatment option for patients. However, there are issues around recognitions by GPs for this disorder. A number of GPs who quite understandably, because they are not cognizant with the best treatment, will tell the patient to either just live with it, get used to it, or basically throw it back on the patient, very unfortunately. But it's a terrible disorder that often lasts for 14 days a month. So for half their life, these women are someone that would prefer not to exist. He said the disorder affects virtually every part of a patient's life and the duration of symptoms can vary enormously. They really need help. They need to have some light at the end of the tunnel. And so I actually tell my patients that I won't stop treating you until I think you are better, he said. You need to try and get these women 90 to 100% better to have a major impact on their life. So being partially treated or a bit better is not good enough. GP and women's health expert Associate Professor Magda Simonis told News GP that traditionally GPs have focused on premenstrual syndrome rather than premenstrual dysphoric disorder, which can be very unpredictable. Now there is a shift towards PMDD as a classification of a mood disorder, which is quite severe and it's only come into our overall awareness relatively recently, she said. For some women, it's not just the decline in estrogen, it's the fluctuation in the levels that they are so sensitive to, and how we respond to those hormonal fluctuations is a variable. You really need to manage women on a person-to-person basis. There are 2 main approaches that we have already discussed. You can use hormonal treatment to stop their period altogether with a continuous pill, especially the more natural estrogen pills, he said. There is a study showing that improves the outlook for about 85% of women, and you have to concentrate on estrogen rather than progesterone. The other arm of treatment is psychiatric medication, says Associate Professor Clement. So the first line of choice for hormonal treatment is the tablet called Zoili, which is continuous. You just skip the inactive pills. And the first psychiatric treatment is something called sertraline. There are a number of psychiatric drugs and antidepressant mood stabilizers that have been tried in people with PMDD and have been found to be useful. As there is no blood test available for PMDD and measuring hormone levels are a waste of time, according to the professor, GPs need to assess this in context of a patient's overall health and that it must be a symptom-based diagnosis. So the common symptoms are depression, anxiety, anger, brain fog, avoidance behavior, where they avoid socializing during the period when they feel unwell. If someone comes in and says their symptoms are severe depression and suicidal thought, then I think one symptom there is enough and you don't need to have anything else. So it's a big article, but I have already spoken about PMDD before. It was one of my very few earlier podcasts that I might share again. But the main arm of treatment is hormones, and number 2 is anti-anxiety medications. In hormones, Zoeli is number 1, along with some extra estrogen patches. And sertraline is number 1, but other pills can be tried too, in which the estrogen component is more than progesterone, until and unless you don't have contraindications to the estrogen. When a woman comes to you with mood symptoms, depression, severe depression, suicidal ideation, and if they are in the age period, anytime between, like during the entire menstrual cycle, anytime from 12 to 13 years when they start menstruating till the menopause, please think about PMDD, premenstrual dysphoric disorder. And of course, menopause can have its own effects as well, similar to this, but PMDD is the most severe, much more severe than premenstrual syndrome, which almost 80% of the women suffer from, but only 10 to 15% women suffer from PMDD, which is a very severe condition, a lethal condition, mentally lethal, and also physically so many debilitating symptoms. GPs, always think about PMDD, please. And women, if you don't know about it, please read about it, listen to my podcasts, listen to other podcasts, and educate yourself about it, please. Thank you.